Good evening to everybody. On behalf of IAP, I welcome one and all. First, to start with the pediatrician prayer, our treasurer, IAP TNC, Dr. Gopal Subramaniam.
Thank you, sir. We'll start today's DIP program, PG Clinics, by our pediatrician's prayer. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையாக குணமளிக்கும் திறனை தாரும். நோயின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்பு என்பதை பணியுடன் நாம் உணர்வுமாக எல்லா குழந்தைகளுக்கும் அவர்களின் குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதர்களாக என்றும் இருப்போமாக. நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் உறுதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். நன்றி.
Thank you, Dr. Gopal. Now I welcome our dynamic president, Dr. Ismail sir, to deliver a welcome address.
Thank you, Rajendran, Gopal, our respected judges, and the chairperson of the day today, Dr. Selva Kumar, professor of Teni Medical College, and of course the moderators, my good friend Dr. Thumuragan, and of course Balakrishnan from Games Hedge. And of course, this is going to be a wonderful learning program for the students. I wish you all a happy learning. Thank you.
Thank you, sir. And now it's my duty to introduce our chairperson, Dr. R. Selva Kumar. He is professor and head of the Department of Pediatrics, Teni Medical College. And he is a dynamic person. He is involving all the teaching program regularly. And he is encouraging students also regularly presenting the cases, and he is developing a lot of postgraduates to present the cases also. I welcome Dr. Selva Kumar sir.
Thank you, sir.
Yeah, I welcome our dynamic joint secretary of IAP and Dr. Thirumurugan Sarane, and he is head Canvich Neonatal Services, AG Padmavati Hospital Limited, Puducherry. I welcome Dr. Thirumurugan. I welcome Dr. R. Balakrishnan. He's my friend and colleague, and he's in senior consultant neonatologist, Kobe Medical Center and Hospital, Coimbatore. I welcome Dr. Balakrishnan.
Thank you, sir.
I welcome today's presenter from Teni Medical College, Teni, Dr. Jaya Kavya, and Dr. Jalil and Dr. Nikita, and they are today's presenter. Now it's over to Dr. Selva Kumar sir, and with your introduction, we can start case presentation.
Thank you very much, sir. This wonderful program conducted more than 1 year for benefit of the PGs. It's very nice program, sir. I thank State President Dr. Ismail sir and Secretary Rajendran sir and Treasurer Gopal sir for giving this opportunity for our postgraduate students to participate in this event. Once again, I thank you all, sir. Thank you very much, sir. Thank you, sir.
Yeah, Dr. Thirumurugan.
Good evening, sir. It's a wonderful opportunity for being here. Actually, I have been part of the PG and UG clinics for the last 1.5 years, a little more than a year, and it has been an absolutely learning curve for me, at least. I mean, at least to recollect and to learn and relearn. So I'm hopefully that we can have a very good discussion. I'm very sure we'll have a very good discussion with other stalwarts here. So let's move on to Dr. Balakrishnan.
Dr. Bala. Yeah.
Thank you, IAP Tamil Nadu State Chapter, for conducting this program on a regular basis. I think it's been a wonderful program for the PGs to learn. And because they're introduced to host different speakers and different chairpersons from all around the state and all over India. So hope this will be a great success as well. Thank you, sir.
Thank you. Now we can start the present, Dr. Jay Kavya. Yeah.
Good afternoon. Good evening to one and all present here. Baby of Ramya, 8th day, male child, informant is mother, reliability is fair. The first born male child born out of non-consanguineous marriage at 38 weeks of gestation by a normal vaginal delivery with birth weight 2.8 kg was initially referred from a private hospital on 3 hours of life as baby not cried immediately after birth to government medical college. Antenatal history, A mother is a 22 years old pregnant, married since 2 years, spontaneous conception. The pregnancy was confirmed by blood test at 4 weeks. She was booked at 8 weeks following a dating scan. She was on regular antenatal visits. The number of antenatal visits was 11. No history of previous medical illness in the mother. Her LMP was 4/11/2020 and her EDD was 11/8/2021. First trimester, no history of hyperemesis, no history of fever with rash, no history of drug intake, no history of irradiation, no history of alcohol, smoking, and substance abuse. Second and third trimester, the quickening was felt at 5th month, no history of increased or decreased fetal movements. She took iron and folic acid and calcium tablets from 4th month, and she had 2 doses of TT at 4th and 5th month respectively. No history of pregnancy-induced hypertension, gestational diabetes mellitus, and anemia during the pregnancy, and no history of maternal fever, no history of bleeding or spotting PV, and no history of any other injections given to the mother antenatally. She had 4 antenatal scans, one at first at the 8 weeks, second at 20 weeks, third around 31 weeks, and fourth around 36 weeks. All her scans were normal, no obvious abnormalities, and Doppler study was normal. Her pre-pregnancy weight was 52 kg. The weight gain during pregnancy was around 15 kg. Intrapartum history. Expected date of delivery was on 11/8/2021. On 2nd of August, the mother had a lower abdominal pain around 9 a.m. in the morning. So she went to the nearby private hospital. Since the pain was irregular and subsided on lying down, she was reassured and sent home. In the evening, around 7 p.m. the same day, she had a lower abdominal pain, which was regular and persistent, increased in frequency gradually throughout the night, and she had a spotting around 8 a.m. next morning. The mother is not aware of the membrane rupture. She went to the private hospital, but she was told that she was in labor and she was connected to an IV drip, and she delivered an alive male child with a birth weight 2.8 kg around 9 a.m. According to the mother, at the onset of labor, there is no history of foul smelling or meconium stain like us, no history of any cord accidents like prolapse rupture, cord around the neck, no history of peripartum fever or dysuria. The baby not cried immediately after birth. Resuscitation details not known. Apgar is not known by the mother. The mother was told following some resuscitation by the doctor, the baby had a weak cry, half an hour later birth, and the baby was shifted to GTMCH by an ambulance with oxygen support and IV fluids. Neonatal history. The baby was received at NICU around 11:40 a.m. that is 3 hours after birth. The mother was informed the baby was in a depressed mental state at the time of admission. The baby had 4 episodes of convulsions on day 1 with first convulsion on 4th hour of life. The mother was informed the baby had convulsions involving all 4 limbs, and the baby was kept under oxygen and was given IV fluids and drugs to control the convulsions. The baby had 2 episodes of convulsions on day 2. Later, the baby was weaned from oxygen support. And after that, the baby didn't develop any convulsions. And on day 3, the baby was slowly started on tube feeds. On day 4, the feeds were increased with gradual introduction of Palladi feeds, and it was totally weaned from IV fluids. On day 5, the baby was on full Palladi feed and mother was asked to give DBF. On day 6, the baby was handed over to the mother. According to the mother, the baby is taking feeds well and mother is able to perceive the suck of the baby. The mother also notices spontaneous movements of the baby and cry of the baby. The baby takes 10 to 12 feeds per day. The duration of each feed lasted for 20 minutes and the baby sleeps for 2 to 3 hours after feed. It passes 6 to 8 urine per day and it passes motion daily. No history of vomiting, abdominal distension, yellow discoloration of skin during the hospital stay. The mother was advised to give the baby 1/3 of a tablet for convulsions daily at night. Family history, the first born male child out of non-consanguineous.
Can we just hold it there and then maybe we can just start the discussion?
Okay.
Is it okay, Dr. Balakrishnan? Sir, Selvakumar sir.
Yes, sir. Yes, sir. Start discussing, sir.
Yeah. So can we just go on to the first slide, please? Can you hear me, Dr. Jayakarni? Yeah.
Yes,
First slide. First slide. You're presenting complaints. Yeah,
This
that's
one, sir?
fine. Yeah. No, first one before that. Yeah. So, what was your presenting complaint for this, or what are the presenting concerns in this child?
The baby was initially referred to some private hospital as baby not cried immediately after birth, sir.
Okay, so the primary concern is that this baby did not cry immediately or after birth. Okay. Now, if somebody gives you that history, would you be concerned? My baby did not cry at birth.
Sir. Yes, sir. I
So,
will ask
so
for
you
other
feel you
histories
should be
also, any
concerned.
antenatal.
So, in other words, I'm asking
Yes,
you,
sir.
is that every baby who has not cried at birth means that they have had asphyxial insult?
Not
Does that
necessarily. Not necessarily, sir. It doesn't mean like the baby didn't cry immediately after birth, and it doesn't mean that all babies need. We have to be very concerned, sir.
So, what would be the more concerning point in this particular child? Is it not crying at birth or something else? And I'm sure that is the reason why they referred, which you highlighted in your history also.
Depressed mental state.
Yes. The need for resuscitation, isn't it? You said that the child needed resuscitation for about half an hour.
Yes, sir.
So that would be a more concerning point for about this child rather than just not crying at birth. Am I right?
Okay, yes, sir.
Okay. So it's a need for resuscitation because for which this child had been needed for a prolonged resuscitation, and that's the reason why this child had been referred. Okay.
Yes, sir. Okay, sir.
So what are the other indicators you would like to find out? I mean, from the history, based on the history, when a child needed resuscitation.
Antenatal, let's start from antenatal.
No, your history was very elaborate and it was very good. We are looking for specific points, isn't it?
Yes, sir.
See, according to your history, this is it's a book mother who has got all the adequate antenatal visits, and still we landed up with a child who needed resuscitation. So what other history would you like to ask?
Any history of medical illness in the mother, which antenatally, like whether she has an hypertension, diabetes, like any other infection in the mother, which would have predisposed to this current situation. And in intrapartum period, like any other, like a placental umbilical cord accidents, like cord rupture, cord compression, might have been happened. And what was the situation of the baby? Fetal heart rate was normal. Was there any deceleration, or what was situation of the baby at the time of labor, around the first stage, second stage? The monitoring part was not available, sir.
Okay. So whenever you look at a child with perinatal asphyxia, you can basically put them into two groups. One who had a kind of chronic or subtotal, who had a hypoxic period for a long time and then they presented with the need for resuscitation. That's one group. The second is a child who had a sentinel event. Okay, the child, the delivery, there might have been a sentinel event, like let's say placenta previa or AP or abruption causing massive antepartum hemorrhage or a cord prolapse, or those kind of pictures. Okay, now it looks like this child did not have such a kind of sentinel event. Okay, so why is it important to know about the sentinel event? Does it matter to the baby pathophysiologically?
It will affect the pattern of the injury the baby might have in future, sir.
Okay.
In case
so what type of pattern you get?
Acute total asphyxia, like in case of cord compression, it will involve the basal ganglia, all the brainstem.
Okay, very good.
Involved, sir. So prolonged chronic asphyxia, it depends upon the baby, sir. It can have parasagittal injury, watershed area can be affected, sir.
Yeah, so the basic difference is in one, you're going to have the basal ganglia which is involved. So these children have a much higher risk of developing cerebral palsy, whereas the nuclear damage, nucleus, various cranial nuclear damage, whereas the other one, you have the watershed areas, particularly between the frontoparietal and the parieto-occipital areas, and then they present with a very different picture, and their prognosis is also slightly different. So thank you. Dr. Balki, anything else you want to ask?
Yeah, as we go to the antenatal history, so what are the specific antenatal risk factors that you're looking for, doctor?
As I said before, sir, any medical illness in the mother.
Very good. Chronic medical illness which can predispose to chronic hypoxia. Yes.
Any infections in the first trimester, sir. Torch infections or any issue of drug intake, any issue of like all these things can contribute to some.
These may not contribute much, but as you said, any maternal chronic medical illnesses in the mother and PAH, especially placental causes like PAH, diabetes. So all that antenatal risk factors are very important rather than all these. Yes, next slide.
Did she take any folic acid peri-conception? Folic acid peri-conception?
No, sir. Only
she didn't take.
She didn't take, sir. From 4
so would you advise her, if she had come to you before pregnancy, would you advise her folic acid?
Yes, sir. Peri-conception, yes, sir.
Yeah, how much would you give her?
400 micrograms. Peri-conception you have to start. Till first trimester we have to continue, sir.
Okay. Dr. P.S. sir here has asked about the weight gain. You said 15 kg weight gain. Is it excessive?
Yes, sir.
So what would be the normal expected weight gain for a primary gravida mother during the pregnancy?
It is around 9 to 11 kg. Based on BMI also we can say, sir. BMI, if it is underweight less than 18.5, it is around 12 to 18. When she is normal 18.5 to 24.9, it is around 11 to 16 kg. When she is overweight, it is around 7 to 11. When it's obese, 5 to 9 kg. Sir.
So what are the possible causes of excessive weight gain during pregnancy?
PH may be one of the causes, sir.
Okay.
Pregnancy-induced hypertension.
Okay. So does excessive weight gain correlate with any other problems?
Polyhydramnios.
Okay. Anything else, particularly in a primary gravida mother? Preeclampsia, pregnancy-induced hypertension, and preeclampsia. Okay.
With regard to the antenatal scans, what specific risk factor that you're looking at is? What specific risk factor are you looking at, Dr. Jayakavya?
Any Doppler study is abnormal, means you can think of any asphyxial event occurring in the antenatal period.
Yes, as Dr. Thirumurugan rightly pointed out, there are situations wherein you have a chronic baby who is having chronic hypoxia, and those babies are more at risk of perinatal asphyxial insult compared to babies who do not have. Like especially, so one of the important risk factors on the fetal side would be IUGR. If baby is having an IUGR baby, is more at risk of perinatal insult than a normal baby without any growth restriction. Yeah. Okay. And obviously, babies with anemia, high drops, all those babies would have perinatal asphyxia as well. There will be need for resuscitation in those babies. Okay. Yep, next slide. So you were talking about intrapartum fetal monitoring. So what is the role of intrapartum fetal monitoring? What are the intrapartum fetal monitoring? What do you want to do in order to categorize the mothers who would need emergency cesarean sections based on what are the parameters that would be taken into consideration apart from your clinical examination?
So fetal heart rate monitoring is mainly done. In that beat to beat variability and deceleration pattern we are seeing. So normal beat to beat variability is 5 to 25 beats per minute. It can be, if it is increased, it's because of fetal movements or a fetal breathing. Decrease, it can be due to any asphyxial events, cord compression, or any risk factor can be predisposed to decrease fetal beat to beat variability. And next is deceleration, can be early deceleration, late deceleration, or variable deceleration. Early deceleration is normally seen in head compression. Sir. Whenever there is like uterine contraction, there will be corresponding fall of the fetal heart rate. This is normal, sir. In case of late deceleration, the uterine contraction has started. When it is reached the peak, then the heart rate falls, sir. Then it will become normal only after the uterine contraction has become normal. It is seen in maternal vascular diseases like diabetes, hypertension, or sometimes uterine rupture, cord prolapse, or cord abnormalities. Placental anomalies can also lead to this. Variable deceleration is totally seen in cord compression. Sir. So here the uterine contraction and fetal heart rate deceleration is not connected. Sir. It will happen in an erratic manner. So based on this, we can plan for an.
So there are three things, as you rightly pointed. The first thing we look at is baseline. What's the baseline heart rate? So the baseline heart rate that you would expect is 110 to 1. So if it is 110 to 100 to 110, it's okay. 160 to 180, they come under category 2. But those babies who have a fetal heart rate less than 100 or more than 180 for a prolonged period of time, so that is significantly abnormal. So any baseline which is less than 100 or more than 180 persistently, 1. As you rightly pointed out, second thing is beat to beat variability. Variability shows, when there is a beat to beat variability, it shows the fetus is healthy. But when there is a decrease in the variability, obviously that points out that the baby is in danger. So decrease beat to beat. Third, as you rightly pointed out, early decelerations are okay. Again, late decelerations only when they're recurrent late decelerations, and when the deceleration is prolonged and it takes a long time for the baby to reach to the baseline again. Those are the times when you will be worried. So recurrent late deceleration take a long time to come to the baseline. And variable deceleration, as you said, if it occurs very frequently for a period of 30 to 40 minutes, then again it's pathological. So we call it a pathological CTG, and based on those fetal heart rate patterns, then a decision can be made whether to subject to an emergency cesarean section or not. Is good. Any other monitoring that can be done, but we don't do often, is fetal scalp pH. Not done very common.
Yes, sir.
Yeah, to assess acidosis in the baby. But what that can be done by bedside in our setting is to do a CTG monitor. Yeah.
Can I move to the next slide, sir?
Yeah, please go ahead. Yes, please.
Yeah, so here the registration details are not known.
Yes, sir.
So is it possible to identify, collect more information? What would be the information which is very relevant in the resuscitation?
What should be asked? Sir, you're asking.
Yeah, what would be, see, obviously, no, you haven't got, this happens very often. I mean, we get references with no details of the resuscitation. Okay, so what history you can ask, which will guide you for further management. Sometimes we get babies who are just not cried at birth, and then they get referred saying that it's asphyxia. And there are babies who are really sick, and then they don't. Then the true picture does not emerge. What history mother can possibly tell us? It can tell. It's a rough guide. It's not something that's concrete.
Prolonged duration of labor, prolonged first and second.
What something you said, some resuscitation was done. No, what regarding the resuscitation? Simple question to ask.
Asking you about details about resuscitation. How to get more information about, though we may not get the exact details like how many cycles of positive pressure ventilation was done, when did we start cardiac compression, how long cardiac compression was. We do not know such things. Like what basic information that you can get from the bystander or from the nurse who is accompanying the baby, like is there any other information that you could get which can help in further management?
From the mother, we can ask whether they have given any tactile stimulation or any compression to the chest, sir, or they have given any oxygen, so that after that the baby cried or not, we can ask. if any staff nurse or any personnel is accompanying, you can ask about the Apgar score. Apgar score to them.
Sorry?
And
Sorry, what do you
Apgar
mean?
score, sorry.
Apgar,
Apgar
yeah,
score.
sure. Yeah.
Okay, couple of points.
The
here.
most important thing, sorry.
Yeah, please go ahead, Dr.
So, the most important thing that I would look at is how long positive pressure ventilation was needed. That would be more appropriate in this scenario. You can ask, like, if the nurse was accompanying, then you can ask her for how long PPV was done. Like, was PPV needed for, like, when did the spontaneous respiration get established? That's an indirect way to ask, like, how the Apgar scores were. And when did the baby started to move? The most important would be the need for PPV, like when you're deciding about therapeutic hypothermia. So one of the most criteria that's decided is the need for PPV for more than 10 minutes. So the child would have needed PPV for more than 10 minutes, that itself will be a significant indicator. Thiru, sir?
Yeah. Absolutely. I mean, that's what I would ask actually, and that is something which mothers who to some extent can say. Okay, it's not and it is very obvious. The other procedures like cardiac compression or even intubation, as a matter of fact, she may not be obvious, but she'll definitely see her child being given oxygen through the face. I mean, the bagging through the face. But of course, as you said, sometimes they might use a mask with oxygen. That also can be confused. But this is quite useful. Okay. Yeah, and you are talking about, you want to ask about the Apgar score, isn't it? Why is it? Do you think Apgar score is relevant even today?
Yes, so the need
Should I ever bother about Apgar score at all?
Sir, I can't get you, sir.
No, should I ever bother about doing an Apgar score? What is the practical relevance? Why should I do an Apgar score? See, normally we do a 1 minute and a 5 minute Apgar score.
Yes, sir.
So what does it do? They have a practical relevance in the current resuscitation scenarios?
If the need for resuscitation is prolonged, sir, for example, if Apgar score is not improving.
Sorry, doctor, there is echo. Sorry, doctor, there is echo.
Yes, sir.
I think we'll get hold of somebody else. No, we'll get hold of Dr. Nikita or Dr. Jalil. Dr. Nikita.
What is the relevance of Apgar in today's era of resuscitation? Why do you do an Apgar? How relevant it is? That's what Thiru sir is asking. Dr. Nikita?
Hello, good evening, sir.
Hello.
Jalil?
Sir, am I audible, sir?
Audible.
The relevance of Apgar score is to initiate therapeutic hypothermia.
Okay.
Even to name it as asphyxia, criteria says Apgar scores less than 5 at 10 minutes or 3 at 5 minutes.
Okay. Fine. So, I mean, though we score often, let's remember that Apgar score is practically not very useful, at least in the immediate resuscitation scenario. Okay, because we talk about the first golden minute. Okay, and whereas we record the Apgar at the end of 1 minute. So we have, if we are waiting for your Apgar score, we have already missed our first golden minute. That's why definitely for the acute resuscitation, Apgar score is not at all useful. Regarding the 5-minute Apgar score, yes, if documented correctly, then it is one of the criteria for for initiation of therapeutic hypothermia, and a 10-minute Apgar score of 3 or less, yes, to some extent correlates with the poor neurological outcome. But even there, up to 50 to 60% of all babies with Apgar score of 3 or even lesser can be normal. So a 10-minute score of 3 or less can be still normal. So it doesn't have a very high sensitivity or specificity. I think it's one of those historical things which we are comfortable doing because it is easy, we think it is easily reproducible. And the other important thing we need to remember is it's all about timing the scores properly and then also calculating the scores properly. That's why I think the current NRP is no longer recommend Apgar score, and it's all about what you just described what went on. That is far more important than mentioning the Apgar score.
Okay.
Yes, sir. Rightly said, sir. So Apgar score doesn't guide us for the further steps in the resuscitation. So we don't use Apgar to guide us for the resuscitation. So we follow the NRP module. As sir said, there should be like ideally there should be one person who should be watching the resuscitation and noting down what all the events that went on during resuscitation. So but as sir rightly said, there's an objective way of looking at how the baby was at 1 minute and 5 minutes and 10 minutes. And we need to continue to score Apgar until we get at least 6 or 7. And Apgars of less than 5 at 10 minutes will give you an indication for therapeutic hypothermia. Yes.
Okay.
And then the next slide, sir.
More, yeah, please move on to the next slide.
Dr. Jayakavi, would you elaborate on the type of convulsions? What type of convulsions did the baby have?
According to the mother, they had informed that the baby had convulsions involving all 4 limbs. So it can be subtle, involving like limbs, cyclical movements, pedaling movements. It can be like that, sir. Exactly, she was not told how many minutes it lasted for.
No, you must have observed in the NICU, right? So you got the history from the mother. Okay. So mother was not sure about.
Mother was not sure, sir. Convulsions can be subtle, clonic, tonic, and myotonic, sir.
What are the neonatal history you would be interested in?
What myotonic?
Myoclonic, sorry.
Sorry. Yeah. What is myotonia, by the way? Because you told myotonic. Sorry? Dr. Nikita or Dr. Jalil?
Muscles cannot relax easily, sir.
Yeah. So it is a condition where there is a very impaired relaxation of the muscles. Okay. And do you think
babies can present like? Sorry, sir.
Yeah, yes, sir. Please go ahead. That's what the question I want to ask. Yeah.
So there is only thing. So those are conditions where they can present like birth asphyxia. Children with myopathies, like myopathies, there are quite a few references which we also had, wherein baby would be floppy at birth and baby would not be breathing, and they would be wrongly labeled as birth asphyxia. This is one of the other differential diagnoses that we should consider whenever the baby is not breathing at birth, not just stick with asphyxia alone. And Dr. Jayakavya, is that okay? Like if you're asking only about your history, entire history is focused only on convulsions and altered sensorium and how far the baby recovered from the altered sensorium status. So is there any other system that you would be interested in when you're dealing with a baby with HIE?
Yes, sir. Kidneys first most commonly involved, like
so it's basically the most important thing that we need to remember is it's a multi-organ dysfunction. Whenever there is prolonged hypoxia, that could be a multi-organ dysfunction. So our focus should not just be on the brain. Yes, our first focus should be on the brain, but we should also be noting down all other systems as well. So what other history that you could illustrate?
Decreased
for
respiration. For respiration, yes. Any meconium aspiration can be there. So any meconium aspiration.
Did the baby need any ventilation or non-invasive support or oxygen? Yes.
Oxygen, prolonged oxygenation, and any bleeding, sir, like coagulopathy.
Absolutely right. Yes, coagulopathy. Did the baby have any sugar issues? Hyperglycemia?
Or metabolic complications also. Hypoglycemia, hypocalcemia can be there. Cardiac myocardial dysfunction. In any
baby could have had feed intolerance. Yes, good.
Feed intolerance, like abdominal distension, they can present like this.
Yeah, good. Sir?
Yeah. Yeah, I'm just still thinking about this history. Regarding, I think Dr. P.S. sir has also asked about the respiratory support. And so whenever you take a history of such a child, okay, any as a matter of fact, any child, there are three aspects which we would like to concentrate on. One would be, what is the illness per se? Okay, because you assume that the child has asphyxia. I mean, you kind of seem to have already decided the diagnosis is birth asphyxia. Whereas I think we have to be more elaborate in making sure that it is indeed birth asphyxia. That is one. The second part of the history which you need to address is what caused this. See, I'm worried about what caused this such a event. Okay. And the third would be, what are the complications outside, which is what sir was talking about. I mean, Dr. Balakrishnan was talking about. So, apart from the conversions itself, okay, we have to look at all the other systems. So you basically have to go system wise. Okay. So based on the history, again, we are just sitting on the history. So what are the history you would like to ask the mother about other system involvement?
Decreased urine output, sir. Any abdominal distension seen? Any bleeding manifestation seen in the baby, sir?
Okay, then beyond that.
Beyond that.
See, CABC link, newborn it's always, so why don't we start with or at least airway breathing circulation?
Okay, sir. Any need for oxygen support, sir? It can be due to any
respiratory support is needed. Okay, fine. Number one. So this baby could have needed just an oxygen. He could have needed non-with support, and she could have had a ventilation. Beyond that, how will you ask for history of shock? If the mother has handled the baby, how will you ask for history of shock?
Any mottling presence of baby become any lethargic?
Okay, she could have seen, yeah, but that is not easy for the mother to say, isn't it? I think most doctors will struggle to say. Beyond that, simple. Very good. If the mother has handled the baby, if she found the babies are peripheries are very cold, that would give us some idea. Again, see, these are all relative now. Please remember, I'm not making it absolute, but that would help. Okay. Suppose we'll come back to the investigation right at the end. Okay, fine. So, what type of convulsions you don't see in a neonate, and why? Dr. Nikita,
your voice is breaking.
Sorry. Okay, I was asking. Sorry, I didn't realize I was not audible. What type of convulsions you don't commonly see in a neonate, and why? Can you hear me?
Yes, sir. Yes, sir. I'm able to hear you, sir.
Yeah, Dr. Nikita, you are around, isn't it? Dr. Jalil? Yes. Yeah. Anybody? It's an open question. Any one of you three can answer.
Because of incomplete myelination.
Yeah. So what do you
usually don't get generalized.
Yeah, you don't get GTCs. Generalized tonic-clonic seizures you don't get. Okay. So because of the incomplete myelination which happens. Okay. So it's usually a multifocal seizure. Now the question is, how will you know differentiate between a generalized tonic-clonic seizure and a multifocal seizure? You are looking at a child, you are finding movements, motor movements involving all the both the upper limbs and the lower limbs. So how will you differentiate between the two?
Sir?
Hello, can you hear me? No, we are not able to hear you. Am I losing it? Dr. Jayakavya, I think maybe you can tell. How will you differentiate between the two?
Hello?
Sir, I'm not able to hear you, sir.
Sorry.
Sir, hello, sir.
Hello, can you hear me now?
Yes, sir. I'm able to hear you, sir.
Sorry. Hello, can you hear me now?
Yes, sir.
Yeah.
Yes,
No.
sir.
How will you differentiate between a multifocal seizure from a generalized tonic-clonic seizure? It's fairly simple. All you have to look at the frequency of the movements. So you'll find that the frequency of the movements is different. One on one limb it might be faster, and another limb it might be a bit slower. And that is probably the easiest way to look at multifocal seizures, even if they appear to be generalized. Okay. Yeah. Coming over here, I think there was a question again from Pierre sir about the mother's impression of the cry. Because you said that the cry is okay.
Yes, sir. After that, when she received the baby, the cry was normal, sir. After on the days 6th of, she was given.
Hello?
The baby was given. The baby was given to the mother on day 6. After that, the baby. Then the mother noticed the baby. According to the mother, the cries, the movements, everything was normal, sir.
Okay. So does she have any concerns at all by the time you met her on day 8?
No, sir. She was not having any concern, sir. And she was primey, and she was like, and I asked her repeatedly, sir. She said no concern, sir. She was in between. She was informed the baby had a weak sex, sir. But she said now the baby, baby is sucking good and it is crying for feeds in between, sir.
Okay.
Doctor, like when you said that the baby was handed out to the mother on day 6, so would that give you an impression about what sort of encephalopathy this baby had? Like, would that help you in prognosticating?
Yes, the baby had a seizures.
Your voice is very low, very low. Can you please speak louder?
Yes,
Hello?
sir.
Sorry.
Hello.
Can you please speak louder, or can you please speak very closer to the mic? Yeah.
Yes, sir.
Yeah.
The seizure has happened on the day. Seizure has happened on the day on the 4th hour of life, sir, and it has lasted. The baby had recurrent seizure until 24 hours, sir. After that, the baby doesn't have any seizure. The symptoms has lasted for 24 hours only, sir. So we can categorize based on this. The encephalopathy might be moderate, sir.
No. My question was, the baby was handed over on day 6 to the mother. So based on that history, so would that help you to prognosticate the HIE here?
Yes, sir. HIE moderate, sir. The baby has.
So what do you think is the long-term outcome of this child?
Outcome will be the baby might be normal, sir, because the symptoms has lasted only for 2 days.
Baby needs a high risk follow for sure. Baby needs a high risk follow for sure.
Normal, sir.
It's very
See, one thing we should never say is the baby is normal, and because there are so many things ifs and buts can happen in between. So the prognosis can be very good for this child because this child was able to feed very well by day 7 of life.
Yes.
Okay.
Whenever the baby starts to feed well directly at the breast, within first 1 week of life, that itself is like a poor man's MRI. To say, okay, the insult is not that bad to cause a severe encephalopathy, or we may not expect a very bad neurological sequel in this baby. But all said and done, this baby has had recurrent seizures. Definitely, this baby needs a high risk follow-up, and we cannot label and say this baby would have a normal neurological outcome. As you're aware, moderate encephalopathy, only about 35% of the babies would have a normal outcome. So, the rest of the babies need follow-up.
Yes, sir.
But definitely, we're sure that this is a better outcome than severe encephalopathy.
Okay, shall we proceed because we are running behind?
Family history. So firstborn male child born out of non-consanguineous marriage. Father's age is 29. Completed his high school. Is an army soldier. Mother's age is 22. Is a graduate. No significant family history. There's no history of seizures in the parents. No history of early fetal or neonatal deaths in the family.
Yeah.
Summary. Can I move, sir?
Yeah, go ahead.
Summary, 8 days male child born out of non-consanguineous marriage, 38 weeks of gestation by normal vaginal delivery with birth weight 2.8 kgs was initially referred from a private hospital. 3 hours of life as baby not cried immediately after birth. The baby had convulsions on the 4th hour of his life. It was a recurrent convulsions lasting for 24 hours. Initially, suck was weak, then it became normal. Now the baby is on exclusive breastfeeding and baby is normal according to the mother. The baby had an asphyxial event, probably HIE stage 2.
Okay, move on to the examination, please.
Examination, the baby is lying in mother's lap in universal flexion, semi-clothed, it is awake and active. No general examination, no pallor, no icterus, no cyanosis, and no edema. Vitals, temperature is 37 degrees Celsius, normothermic, heart rate is 130 per minute, normal in rate, regular in rhythm, respiratory rate is 48 per minute, NIBP was 60, 40 mmHg, SpO2 was 99% under room air, CRT is less than 3 seconds, and all vitals are within normal limits. Anthropometry, the birth weight was 2.8 kg, gestational age, current weight is on day 8, it is 2.66 kg. The weight loss is within the normal limits. His length is 50 centimeter, appropriate for the age. Head circumference is 35.0 centimeter. Head to foot examination. Hair is normal. Head normal in size and shape. No overriding separation or ridging of suits. AF is wide open, flat, not pulsatile. PF is not open. No caput succedaneum or cephal hematoma. Face, no obvious dysmorphism. Eyes, ears, nose are normal. No cleft lip, cleft palate. Neck normal. Chest normal. Umbilicus shriveled. No bleeding or discharge. External genitalia is normal. Spine is normal. Limbs are normal. Palms and soles are normal. Hips normal. Nervous system, higher mental function. The neurobehavioral state is awake and active. Baby is consolable, cuddable. Habituation to touch, sound, and light is present. Cranial examination. First cranial nerve not tested. Optic nerve, pupillary reflex is present. 3, 4, 6, extraocular movement is present. Spontaneous eye movements and doll's eye movement is present. Cranial nerve 5 and 7, rooting and sucking is present. 7th nerve, no facial asymmetry, no obliteration of nasolabial fold. Able to close the eyelids during vigorous crying. No deviation of angle of mouth. Vestibulocochlear nerve blinks to the sudden loud noise. Startle reflex is present. Cranial nerve 9, 10, 11, and 12. Sucking, swallowing is present. No history of drooling of saliva or milk. Palatal movements were normal during swallowing. Motor system, tone, passive tone. Posture, universally flexed posture. Tone on passive movements appear normal. Active tone, 190-degree flip test. Pull to sit, held sitting, held standing, vertical suspension, horizontal suspension, prone position, all were present. Power, spontaneous anti-gravity movements were present. And the best observed power would be more than 3/5 in all 4 limbs. The movements were symmetrical in all 4 limbs. Deep tendon reflex, knee jerk is normal, present on both sides. Bicep jerk is normal, present on both sides. Superficial reflex, plantar and extensor response, present on both sides. Developmental reflex, rooting and sucking is present. Morose is complete and symmetrical. Palmar grasp is present. Plantar grasp is present. Stepping reflex is present. Walking and placing reflex was present. Asymmetric tonic reflex is present. Cerebellum, no nystagmus. Spine and cranium is normal. Respiratory system, air entry equal on both sides, no added sounds. Cardiovascular system, first heart sound and second heart sound is heard, no murmur. Abdomen, soft, non-tender, no distension, no organomegaly, and bowel sounds were present. External genitalia, normal. Bilateral testes descended, they are present in the scrotal sac. Eight days old male child born with 2 kg. My private has died immediately after the occurrence lasting 24 hours. Initially was the late he regains it. On now neurologically normal excluding, the baby probably had aspect event in the postpartum period. Etiology is perineal asphyxia, presumed HAE stage 2.
Can you go to the start of your examination slides, please?
I think she has lost network.
No, she has just rejoined, sir. Just
Okay.
rejoined. Okay, so while we wait, can I ask one of the other two? How will you assess the state of alertness of a neonate? What are the parameters when by which you will say a baby is alert or is drowsy? Dr. Jalil?
Yes, sir.
Yeah. So how will you say that a child is, what parameters will you take into account before while commenting on the alertness of a child, of a newborn?
Yeah, if the baby, whether it is attaching well to the mother.
If mother is not around,
whether
we
it
cannot
is,
say, is it?
if
Baby
the
is there
baby
in
is
front
crying,
of
we can
you. You are looking at the baby. So you are going to say how is the baby is alert or not. There are some parameters you look at, isn't it? So what are the parameters you look at to say if the baby is alert or not?
startle reflex, we can say, sir.
இல்ல அலர்ட்னஸ்க்கு தொட கூட மாட்டீங்க பேஷண்ட். Hello, can you hear me? Okay. Fine. Okay, because they are not, there seem to be a drop. Okay, there are 4 things we look at when we comment on the alertness or behavioral state of a neonate. Okay, first is the eye opening. Is the child is having a spontaneous eye opening and is he able to look around? Okay, that's the first thing to look at. The second thing to look at would be the respiration, particularly a child who is in a deep drowsy. Very often the respiration may not be regular. Okay, so you have a regular normal respiration. The third point is the gross movement. If the child is having good spontaneous movements, which is symmetrical. Okay, and the fourth part is the vocalization. Is the baby able to cry, and is the cry normal? So we look into all these 4 things, and then before commenting on the alertness of a child. Obviously, an alert child is going to open the eyes. He is going to move his arms and legs, and he is going to cry. Obviously, a child who is drowsy is not going to have his eyes closed. With the limp and with no movements, and obviously it's not going to make any sound. So that's what you look at when you comment on the drowsy, because she mentioned about the drowsy child right at the start and in the initial history itself. Dr. J.K. Kavya, have you joined us? Hello?
Yes, sir. There is some problem in here, sir. Joined now, sir, currently.
You joined now. Okay, fine. Can you project your slides again, please? Sorry, again, while we wait, one of the others, can you just talk? I mean, she mentioned that she has not checked for olfactory nerve in a neonate. How easy is it to test for olfactory nerve in a newborn, and how will you do that? Examination.
Sir, mothers, the baby is reacting to the mother's milk. Sir.
There are two devices you are connected to. Can you just turn off one device?
Have you connected with 2 devices? Hello.
Hello. Yeah, you're fine now.
Hello, sir. It's better now, doctor.
Yeah, it's much better now. Please go. Can you go to the start of your examination?
Yes, sir. Sir.
Yeah, one positive point. All three judges have felt your slides regarding the photos of the newborn reflex are very nice. So congratulations.
Thank you, sir.
Yeah. Can you just go to the next slide, please?
Can you go back further? Go back. In anthropometry,
yeah. Sorry, yeah. Please go to anthropometry. Yeah.
Oh, sorry. So in anthropometry, which is the most important parameter that you think is important here, Dr. J. Kavya?
For this baby, sir?
Yes, for this baby. Like you're looking at the baby now.
Circumference.
Yes, absolutely. Why?
Because if the baby is going for any, we can follow the baby's head circumference serially, sir, and we can comment upon the any head development of the babies.
Yes, absolutely. So we need to know the baseline head circumference in these babies because that will help us to follow them up. So we may not be able to do regular MRIs for these babies to know whether the brain is growing or not, but the baseline head circumference is well taken. So if you've taken this head circumference, let's say for example 37, and you see the baby again at the first vaccination, and you see that still it's 37, then you may be wondering that head size is not growing. So a properly measured baseline head circumference for these babies go a long way in helping us to predict how the brain is growing. So that's the most important factor that needs to be taken. But if it was 32, and again you see at 1.5 months the head circumference 34, 36, you're still happy. Okay, it's growing. Okay, so baseline head circumference is important. And what is the rate of rise of head circumference? Normal increase in head circumference.
Well, first initially for first 3 months 2 centimeter per month, 3 centimeter per month. The next 3 months. For the rest of the last half months, we 1.5 centimeter per month.
Okay, go ahead.
Okay.
So head to foot examination, sir.
Yeah, please move on to the next one. Yeah.
Shall I move?
No, just go back. You mentioned no caput succeedium on a day 8 child. Do you expect caput to be present on a day 8 child?
No, sir. It obviously disappears by 24 to 48 hours.
Yeah, so that is something probably you should be careful.
Okay.
Okay. And what are the conditions where you get a posterior fontanelle which is open?
Hypothyroidism, sir.
Okay.
Even hydrocephalus, megalencephaly.
Yeah. Any genetic syndromes?
Beckwith-Weidman syndrome.
Beckwith-Weidman, I'm not sure, but anyhow, possible. I don't know. Then it's very common. Definitely, you would have seen at least 10 by now, if not more than that. Down syndrome. Trisomy 21.
Down syndrome.
The trisomy 21 you can get it in Russell's fever. Anyhow, okay, fine.
Can I move to next slide, sir?
Yeah. So you said the hips are normal. How did you ascertain the normalcy of hips? What test did you do?
Ortolani test and Barlow's test. First, initially, any limb length discrepancy is present, and asymmetrical posterior crease is present. You have to see, sir. Then we'll be doing for examination.
Asymmetrical posterior crease.
Gluteal. Gluteal region
Anterior
at the
posterior, Appa.
feet.
The asymmetry is not posterior, ma.
Yes, sir.
It's asymmetry of the medial creases, not the
Barlow's test.
posterior creases. Okay. And how will you do the
Okay,
Barlow's
sir.
test?
Barlow's test, adducting the hip and moving the femoral head posteriorly, sir. We're dislocating the hip.
So
In
you are looking
autology,
for a
abducting and
dislocability.
bringing the.
Yeah, go.
In autology, we are abducting the hip and bringing the femoral head anteriorly, sir.
Yeah. So one test you would do with both hands, another test you should do only on one side. Which test you do it with both hands? Another which test you do it with only one on one side?
Autology on one.
Yeah, autolone is
Autology with both hands, sir.
exact opposite. Okay, please remember Barlow's is the one which is we are looking for a dislocatable hip. So and where you can do it with both hands, whereas autolone is you should do only with one hand. If you try to do with both, there is a risk of a fracture. Okay, so you should be very careful doing autolone. Okay, fine. Fine. Dr. Balki, where the solma? Anything else, Dr. Balkrishnan?
No, sir, no. But you should look for obviously neurocutaneous markers.
Yes, sir.
In your child with seizures, obviously, you should look for any neurocutaneous. Yeah.
Okay. Did you do a fundus examination in this child? Why is it relevant?
Like chorioretinitis, like torch infections, we can.
In the child. What finding can be present in this child?
Increase the ICP means we can see for papillary edema, sir. If the baby's
okay, fine. That is unlikely because given the child has got a normal neurology and a normal head circum, so very unlikely. There are two findings which you should look for in this child, which can be obvious at this age, at about a week or so. One is probably disappearing, another one is just appearing.
Red reflex, sir.
Okay. Red reflex is normally you would see, but in this child specific of fundus examination, red reflex you don't look for with the fundus, isn't it? So the two findings, one is presence of retinal hemorrhages, but please remember up to 40% of normal newborns can have a retinal hemorrhage, but it kind of helps, but you can have quite massive hemorrhages. But luckily, most of these hemorrhages resolve spontaneously without any treatment. And the second thing is, not in this case, but very severe HAE, this child should be fine, but you can develop optic atrophy. So those are the two findings you can look for in a child like this with fundus during fundus examination. Okay, move on, please. Sorry, my apologies. Yeah, please go ahead. Selvakumar sir, நீங்க ஏதாவது சொல்றீங்களா sir? Anything else to say, sir? Come on, sir.
Carry on, sir. நீங்க கண்டினியூ பண்ணுங்க sir.
Yes, sir. Okay, please move on. Yeah, next slide. Okay, so I asked this question while you were off. You said that olfactory nerve is not tested. So how easy is it to test the olfactory nerve, and how will you test it?
If baby is able to recognize the breast milk of the mother,
okay, fine.
Mother can obviously notice and say.
So how will you know that the baby is recognizing the family smell of breast milk? No, that's a perfect answer. That's a right answer. Very good, actually. Congratulations. But how will you know that?
Baby might have some cues, sir, on.
Cues. So one is baby might like to turn around and then see the side of the smell. The second is he might have some sucking movements. Okay, those are the two pointers for us to clinically look at and then say if this child has got a olfactory smell, as a normal olfactory smell. Okay.
Yes, sir.
So
Yes, sir.
the other thing you mentioned is about the pupillary reflex. Okay. So any other way of what other way of looking for testing the optic nerve in a neonate? What is basal reflex? Anybody else? Any of the others?
Basal reflex, sir.
Basal. DAZL. Is a reflex of Piper. Anybody else? Okay, fine. So basically, no, it's something. It's nothing extraordinary. So you shine a high intense light onto the child. No, the child closes the eyes very tight, isn't it? And then the beauty of this reflex is that it continues to close the eyes till the intense light is present. Okay, it is obviously uncomfortable for the child, but it is a rough indicator of your optic nerve. Okay, fine. Testing the optic nerve. And in an older child like this, you can also do how else we can test the optic nerve. You can look for use a red cotton wool. Yeah, you can use a red cotton wool to see if the child is fixing and following just with the eyes. Another thing is orthokinetic nystagmus, which you told. Yeah, that's right. Dr. Balakrishnan, anything else? Yeah.
No, sir.
Okay. Which now cannot be tested that easily in a neonate? 11th now. Okay, fine. So it's difficult to look at the motor component of the 11th now. So that is one which cannot be tested that easily. Okay, please move on. Very well. You are doing very well. Go ahead.
So, Dr. Jacob, if this baby you would have been the doctor who would have received this baby on day 1. So, how would you categorize this baby into different stages of encephalopathy? What are the parameters that you would look at to categorize the stages of encephalopathy?
Based on Sarnat and Sarnat classification.
Yes.
On the time of examination, you are asking, sir?
Yes. You are receiving the baby in the NICU at the 3rd hour of life. The baby has come to you, and you are assessing the baby. The initial assessment. So based on the initial assessment, how do you score the baby to be in which stage, whether it's mild, moderate, or severe?
On the first day, the baby's level of consciousness, the baby was lethargic, sir. And the spontaneous movements were decreased, and it had a mild hypotonia, sir. And baby's moros were weak and incomplete, and suck was weak, sir. The baby had a seizure on the day 1 of life, that is within 24 hours. And the symptoms lasted for 2 days, that is around 2 days, 24 hours, sir. On full 24 hours, the symptoms lasted. So,
there are only 6 parameters that you look at. Yeah, main thing, like it's a modified Sarnat. Sarnat, there are lots of parameters that we look at, but obviously 6 is what we use for the NICHD criteria. One is level of consciousness, as you said, whether the baby is alert,
suck,
whether
respiration.
Yeah,
level of consciousness
and tone
of the baby, sucking and respiration. Seizures, sucking and respiration. Levin's index.
No. We have followed the modified Sarnat staging, wherein these 6 things: one, level of consciousness, tone, posture, activity. Then you look at the primitive reflexes. Primitive reflexes look at the suck and moro. Then autonomic nervous system, which you look at the pupils and the respiration. Okay. So if the level of consciousness, the child is irritable, lethargic, or the baby is comatose. Then posture, how is the posture? Then activity. Then you look at the primitive reflexes as well as the autonomic nerves. So you include all these 6, and if the baby has 3 of the 6 is positive on one side, then that baby is supposed to a moderate encephalopathy or a severe encephalopathy. So based on that, we can decide whether the child is moderate or severe. It's more easier way of classifying rather than to go through the entire checklist.
Yes, sir.
Yeah, Yeah, please go ahead. Yeah. Yeah, next slide, please.
Shall I move on with examination? Next slide, sir.
No. Just this slide actually is a very good slide because it shows you about the headlamp, isn't it? So how will you classify headlamp when you pull to sit? I mean, that's probably the right way to do a headlamp. So how will you classify the headlamp?
Sir, it is like almost complete head lag, sir. Initially, the head will momentarily, the baby will be holding the egg. Then
So
it
let's
will
say when
fall for
the head lag is very severe, what do you mean by it? So when will you say the head lag is very severe?
hypotonic.
There are 4 grades. So how will you say that? So when the head is completely lagging behind, okay, and the baby does not make any attempt to lift the head, okay, that would be severe head lag. The next grade would be, yes, the head is completely lagging behind, but the baby is trying to momentarily lift the head, okay. And then the third one would be when the head is when you're lifting the child, the head is coming to the midline, but then is not able to hold the posture and it falls either forward or backward. And the last one would be when the child is able to bring it to the midline and also able to maintain the head posture even though there might be bobbling. Okay, so that's how you will say the child has got the head lag. Okay, next one, move on. What did you look for here when you make the child sit? No, what did you look for?
The child's back was rounded, okay. And the head, it was like it was holding the head momentarily, sir.
Okay. I mean, neurologically, this child looks very impressive. Okay, please move on. We'll go on to the investigation management. Please move on. Next slide. Yeah, please go ahead. Please move on to the next slide, please. Yeah, move on. Okay, regarding the Moros, okay, so can you just go back? So how will you, what are the different phases of a Moros reflex?
Abduction, first abduction of the abduction at the shoulder, extension at the elbows, and opening of the hands.
What is the first one which happens?
Before abduction, sir?
What happens to the hands and the fingers?
Hands of the, sir, I'm not able.
Hands and fingers. That's where you see
opening of the hands and fingers.
Opening of the hands and the fingers of the hand. Then there will be abduction. Then
extension at the elbow.
And finally flexion. Okay.
Flexion, closing, flexion, and adduction at the.
How will you say that Moros is exaggerated?
The threshold is very low, sir, and there's no habituation.
Anybody else? Usually when the Moros is exaggerated, the child holds the posture at the end of your posture. So you have the flexed posture continues and it does not, the child rarely relaxes. Okay.
Yes, sir.
Move on, please.
Dr. Jayakavi, how do you do ATNR? Asymmetric tonic necrosis.
Placing the child supine, sir, head with the head in the middle, turning the child face to one side. On that side, there will be extension of the upper limb and lower limb. The side where the caput faces, there will be flexion of the upper limb and the lower limbs.
What is this posture called? Called the fencing posture, like fencing, like they do like in Olympics, fencing. So fencing posture. So what is the importance of this ATNR? How significant is in the development of the infant? When it should disappear?
Only when this reflex disappear, there will be rolling over of the child, sir.
Yes.
So it
yes.
disappears
Most
around
of the-
4 to 5 months.
Absolutely, very good. So ATNR has to disappear for the baby to roll over, and that's what happens most oftenly in CP children. They'll not be able to roll over as long as the ATNR is intact. Yes, good.
Yeah. Please move on. Next. Yeah, go to your summary slide, please. A summary slide.
Summary slide, sir.
Yeah. So you said the etiology is perinatal asphyxia, presumably HA is changed too. Okay, what are the differential diagnosis for a child who is presenting like this?
Differential type for this child, sir?
Yes.
Child who
Child
presents
who did
with
not
recurrent
cry at
seizures on day one and encephalopathy. Yeah.
Metabolic reasons can be, sir, hypoglycemia, hypocalcemia, any intracranial hemorrhage.
Okay.
On day one.
Again, see, think about it as this child did not cry at birth, and then he presented with seizures later on. So, what are the possibilities? I agree. Which metabolic disorders can present like this? Which genetic IEMs can present like this?
What are the
Organic
HIE mimickers? What are the HIE mimickers? Like rare disorders which can mimic HIE?
Organic acidemia.
See, you think about it as
Usually organic acid.
Amino acids.
You can think it at a cerebral level, at a neuromuscular level, at a peripheral nerve level, and at a muscular level. So, what are things which you can think about?
All neuromuscular disorders can present, sir.
Yeah, which neuromuscular disorder?
At anterior horn cell level, acute infantile spinomuscular atrophy can present, sir.
Oh, not in day one of life.
Not.
You ask the history. So you talk about this neuromuscular disorder. You ask the mother the history. She will give you the diagnosis. If you just ask the mother the history. Congenital myasthenia. Very often it is linked with the maternal myasthenia as well. Because you told neuromuscular, I was just saying that. Okay. The other possibility is myotonic dystrophy congenital myotonic dystrophy can present as a similar to HAE. Then severe congenital myopathies can present. Okay. Then certain genetic conditions like Zellweger's, they can present. Okay. In the neonatal period. And, again, inborn error of metabolism, mainly non-ketotic hypoglycemia. Okay. Molybdenum cofactor deficiency.
Pyridoxine deficiency. Pyridoxine dependency.
Okay. Fine. Please move on. Go on to the management, please.
How will you differentiate? Sorry, Jacob. So how will you differentiate? So as I said, you can have a child with myopathy or a myotonic dystrophy or a congenital myasthenia baby presenting to you with not crying at birth, and then baby needed resuscitation. We classify it as HIE. So anything which can help you to differentiate, what investigation will help you to differentiate? What investigations of these, you have listed all these investigations, right? Which investigation is crucial for that? Bedside investigation?
EEG.
Yes, EEG is something which will definitely help you. EEG would be absolutely normal in these things. So, like especially babies who are related to the myasthenia or a myopathy baby, EEG will be absolutely normal. Whereas if you're dealing with NKH or sulfate oxidase, they can have abnormal EEG. NKH basically has a burst suppression pattern. So all the IEMs can have abnormal EEGs, but these children, they will have normal EEG. Yeah.
Okay. So regarding your investigations.
Baseline investigations, sir.
Okay. So you have done a blood sugar. So why is it relevant?
Hypoglycemia can be a cause, or it can precipitate seizures, sir.
Okay.
Hypocalcemia, throughout hypocalcemia,
So what is the principle of treatment here? So you should maintain euglycemia. Hyperglycemia can elevate your lactate levels. Hypoglycemia can further worsen your cerebral injury. So this is something that can be done by all of us by the bedside. We don't want to make the neurological insult more. So maintaining euglycemia is very important in these babies right from start. Okay?
So let us say you are the resident and then your intern comes and tells you that the blood sugar of this child is 300. Would you be happy or sad?
300 is high for
300 milligram per deciliter. Yeah.
It's very high, sir.
So why do you think this is happening and how is it relevant to the prognostication? It's well documented that hyperglycemia, children who have got neural hyperglycemia have a very bad outcome when compared to babies who have got euglycemia, even hypoglycemia when compared to hypoglycemia. So it's again, when you're discussing it, these are all simple factors. See, if you look at prognostication, there are some really expensive investigations which we can do. But we are looking at simple tests which we can do at a bedside where when you talk to the mother, you can say, so I would be rather quite cautious if I get a blood sugar of 300, even before I start treating this child. I'd be very cautious about the outcome for this child. Okay. That's probably what I would have done. Okay, fine. Yeah, please go ahead.
Sir, or ABG to see and document acidosis, sir.
Okay, does this child have a EABG at all? Did we manage to get that? No, wait, fine. That's all right. Okay, fine. Okay.
Serum urea and electrolytes, sir. LFT. And EEG monitoring to record seizures. Okay. Initially, ultrasound to see
in the LFT. Why do you want to do the LFT?
MRI brain, sir.
What are the abnormalities that you see with electrolytes? What are the abnormalities that you're looking for? And when would you do it in a baby with HIE?
Hypomagnesemia can be there, sir. Hyponatremia.
Most common would be hyponatremia, right? So
hello,
why is there hyponatremia? Hello?
SIADH. Please go.
Can the others join in? Actually, I'm not able to hear their voice at all. Dr. Jalil, Dr. Nikita.
Nikita.
Yes, sir. SIADH.
Yes.
Yeah, maybe Dr. Nikita, you can answer the question. What are the different electrolyte abnormalities you see in a child with HIE?
Hyponatremia, sir.
Yeah, so why do you get
hyponatremia?
Hypomagnesemia.
How could you prevent? No, how could you prevent hyponatremia? What are the causes of hyponatremia?
SIADH, sir.
Yes, SIADH. So, how do you prevent hyponatremia?
Judicious fluid management should be.
So, how do you judiciously give fluid?
Sir?
How do you give a fluid? See.
Hello.
What parameters would you consider while giving fluid? That's what sir is asking. What parameters you would consider when you're administering fluid? Jalil, Dr. Jalil?
Yes, sir.
Yes, sir.
So if hyponatremia, when it is suspected secondary to SIADH,
fluid restriction has to
fluid should be restricted.
Yeah. So do you universally restrict fluid for all these babies?
Not routinely, sir.
Okay.
Because it will predispose to
Nikita, maybe if you have to turn off your mic. You're getting, yeah.
Not routinely will restrict fluids, sir, because it will predispose to hypoperfusion. Only if there is documented hyponatremia, when serum sodium level is less than 120, we can restrict fluids, sir. Or if there is any renal failure, we can restrict fluid.
So would you wait for serum sodium of up to 120? How will you define severe hyponatremia in neonate?
Less than 120, sir.
See, please remember, it is less than 125 itself. You should be very careful on your name. Okay. So for handling, so you need to look at not multiple factors before deciding the fluid prescription for a child. Okay, the factors which you would consider, one obviously would be the urine output. The second would be the perfusion, and that can be guided by if you have the facilities to do an echo. Okay, because many of these children, more often than not, we assume that they are fluid loaded, and then we restrict fluids, and then they end up with shock and unnecessary cardiac, vasoactive drug treatment. So we probably would be very careful in giving fluids, and most of them would benefit from the normal or even a slightly higher amount of fluid. Okay. So coming back to the question on the LFT, because Dr. Balakrishnan was asking about LFT. So what abnormalities you would like to look at in a LFT? Again, another poor man's test for telling us, giving us a clue about what is going on.
One more thing that you can, one more parameter that can help in deciding the amount of fluid would be daily weight check. So if the baby is gaining weight, then obviously you should be very cautious on the fluid. You should allow the baby to follow the natural course of weight loss rather than allowing the baby to gain weight. So recording the weight daily and comparing with the previous day's weight will also help you in deciding the amount of fluid.
Okay, sir.
Okay, LFT, what else you would like to look at? You order the LFT, results will come. What is it you want to look at?
Increased
yeah?
hepatocellular enzymes, PT, APT will be prolonged in case of coagulation abnormalities, sir.
PT, APT,
liver enzymes will be increased, sir.
Okay, so usually these children who have had a significant hypoxic insult, they would have quite marked elevations in liver enzymes. And particularly, you can see this even within the first 12 hours. And that is one of the indicators to say about a hypoxic insult for a child like this. Okay. And you mentioned about EEG. I think we'll skip that because what about neuroimaging? You want to do a cranial ultrasound in this child. How effective is cranial? Good is cranial ultrasound? What findings do you expect in a child like this?
If you are planning for therapeutic hypothermia, we can exclude intracranial hemorrhages using cranial ultrasound, sir.
But the intracranial hemorrhage is not an absolute contraindication for therapeutic hypothermia. So what findings, what instead of excluding, what are the things which we can look for when we are looking for a child like this? What findings can you look for? Dr. Jalil?
Ventricular.
Periventricular leukomalacia in case of
definitely
preterm.
not on day one.
So if you find any porencephaly or a cystic encephalomalacia at birth, what would you think? What is your impression about the etiology?
Sorry?
No, Dr. Jalil, if you're going to see cystic changes in the brain at the time of birth, soon after birth, in ultrasound cranium, so what does it suggest you? Is this insult a perinatal insult or an antenatal insult?
Antenatal insult, sir. Maybe
yes. So normally
obstruction to the
for you to
frog
develop for you to develop a cystic change in the brain or a leukomalacia in the brain, it needs at least a month or so. Okay, so this is what you're looking at. Leukomalacia or porencephaly is the result of an insult that must have happened weeks ago. Okay, so that points to a point of an antenatal insult, not an intrapartum insult.
Okay. So regarding the ultrasound changes, the changes you look for would be areas for focal infarct. So how will you look for a focal infarct? You will find the areas of hyper density, particularly in the cortex, but more importantly in the basal ganglia. And if you can do via the posterior fontanelle, then you can look also at the cerebellum, where you can see the midbrain. That is one. The other important finding you can look at would be the loss of differentiation between gray and white matter. That would suggest to us that this child has got a cerebral edema. Okay. The other features of cerebral edema would be a narrow or slit-like lateral ventricle, and also it's very unusual to see a midline shift in these children. Okay. In fact, neonates is almost unheard of. And the last point, which is quite useful, which a lot of people have found to useful, is to measure the cerebral blood flow in the anterior cerebral artery. So you can find resistive indexes, and if the blood flow if the resistive index is less than 0.65 or more than 0.95, it usually indicates that these children, they actually do very poorly. Okay, so ultrasound is a fairly useful investigation when and in fact now they say that with the newer high definition ultrasounds, they are up to 9. They correlate with the MRI up to 90%. So in places where we do not have a MRI in the unit or in the center, ultrasound is pretty useful for our management and guiding our treatment. Okay, so please move on. Anything else? So one more investigation I would have done in this child. Okay, and again it is useful to look at a multi-system injury. Would be to look at the urine routine. So what will I find in the urine routine in this child? Do a dipstick of a urine. Quite useful.
Proteinuria.
Illa.
Beta to microglobulin.
Beta to microglobulin.
No dipstick will give me that.
Hematuria.
Sorry?
Hematuria, sir.
Yeah, hematuria. Okay. So presence of hematuria tells me that there is a renal injury. Okay, another pointer to look for a multi-system involvement, isn't it? So it is again quite useful. Yeah, please move ahead. Next slide, please.
And again, when you're doing a blood count, anything specific that you look for in the peripheral smear, Dr. Jalil? Like say, for example,
nucleated RBCs.
Yes, very good. So how will that be? Like normally it will be said that the total count is very high. So this child, like at the time of birth, the hemoglobin would be 16, and the total count would be 40,000. So if you're seeing a very high white cell count in a baby who has had asphyxia, you should always specifically ask for nucleated RBCs, because nucleated RBCs are counted like WBCs by the Coulter machine. So they have to look at the peripheral. What is the normal number of nucleated RBCs? How do you measure them? You measure them in terms of, you measure them per 100 WBC. So normal nucleated RBCs that is present would be about less than 5 nucleated RBCs per 100 WBC. If it is more than 10, it suggests the insult was high. Probably the marrow was hypoxic for a long time, and that would have produced more nucleated RBCs. There are a lot of studies to say even prognostication also, if the nucleated RBCs are more than like 20, 25 per 100 WBC count, then that suggests probably the baby's insult, the asphyxia might have been prolonged asphyxia. Okay, and the baby must have subjected to a prolonged hypoxia. And regarding radiology investigations, so when would you like to do an MRI?
Around conventional MRI can be done around 7 to 10 days of life, sir. Preferably after 14 days.
Why? Why do you want to do it after 14 days?
Probably the insult would have been evolved and progressed. That gives prognosis. So late MRI gives better sensitivity.
So if you have an advanced MRI machine which can do a diffusion weighted imaging, so normally we look at two things: whether changes in the diffusion weighted and changes in the T1, T2. So what diffusion weighted imaging changes will be present for the first 1 week or so. So after 1 week to 10 days, you will not see the diffusion weighted imaging changes. So if you want to do an early MRI that's done at first 5 days of life, which may not be really useful. So what would be best would be to do it at day 5 to day 7. If your MRI has a diffusion weighted imaging, as well as if the MRI has an MRS spectroscopy. But if you don't have that, if you have a normal MRI which does only T1, T2, then probably the right time would be to do it at day 10 to day 14. As you said, we would have evolved, and for prognostication, that will help us. So what are the injuries that you're looking at for prognostication in MRI?
Selective neuronal necrosis. Patterns.
That is pathology, neuropathology that you see on the slide. What I'm telling you, what are the areas that will be involved to classify the severity of the injury based on MRI? What are the areas that will be involved in HIE?
Posterior limb of internal capsule.
The altered signal
Yeah,
intensities in
abnormalities.
click. Posterior limb of, but most important would be to look at whether where are the areas of pattern of involvement, whether the involvement of cortical and subcortical regions, especially in the watershed areas, and involvement of deep gray matter. So if you see signal changes in the deep gray matter, what are the deep gray matters you're looking at in MRI?
Thalamus, basal ganglia.
Yes, absolutely. So most important is to look at whether there are changes in the thalamus, changes in the basal ganglia, and to look for changes in the white matter, subcortical changes, whether how extensive they are, and look at altered signal intensities in posterior limb of internal capsule. If you have altered signals in the deep gray matter, altered signal intensities in PLIC, then that prognosticates that this child might need a rigorous follow-up and would need early stimulation. Okay. Right.
Okay.
Sir, do you want to add, sir?
Yeah. No,
Sir,
nothing
do you
else
want
actually.
Yeah.
No, I'm fine. Sorry. Yeah, I'm fine with it. So regarding the neuroprotective strategies you talked about, so did this child qualify for a neuroprotective strategy? If you had all the facilities, do you think you would have cooled this baby?
Yes, sir.
So in other words, I'm asking what are the...
Yes, sir.
Jalil, நீங்களும் yes சொல்றீங்களா?
Jalil?
Yes, sir.
Yes, sir.
Yes, sir. So unanimous agreement. So what are the indications for putting in a neonate?
So first, the gestation age has to be more than 35 weeks and the weight of the baby has to be more than 2 kg.
Okay.
And therapeutic hypothermia should be started within 6 hours after birth, sir. And there should be any evidence of birth asphyxia, like Apgar score at 5 minutes should be, sir.
Yeah. You said within 6 hours.
Hello?
Yeah, that's right. Yeah.
Within 6 hours.
As early as possible. Yeah.
Then Apgar score at 5 minutes should be less than 5. And the need of intermittent pass-through pressure ventilation till 5 minutes.
No, Apgar score at 10 minutes should be less than 5.
7, and the base deficit should be.
Okay, if somebody does a pH, then a base severe acidosis less than 7 is useful. Okay, fine. So in this child, why did you say that this child needed a therapeutic hypothermia?
Plus, there should be evidence of encephalopathy. Apart from these factors, as you said, like 35 weeks,
Yes,
hours, then presence of asphyxia. And plus, there should be evidence of moderate or severe encephalopathy. And when you talk about Apgar should be less than 5 at 10 minutes. And PCV, need for PCV or assisted resuscitation for more than 10 minutes. So those two would be taken as a surrogate marker. Yeah.
And there should be a staging of encephalopathy.
Dr. Nikita, a lot of background noise, doctor. Lot of background noise. Only use a single device only.
Yeah, please go ahead.
And there should be any clinical seizures and altered state of consciousness like lethargy, stupor, or coma, and any one of the following like hypotonia, abnormal reflexes including oculomotor, pupillary abnormalities, absent of weak cells. These all are the indications in case of therapeutic hypothermia.
Okay. So how will what temperature would you cool?
The optimal temperature should be around 33 to 34 degrees Celsius.
Okay. So ideally it will be about 33.5 plus or minus 0.2 degree centigrade. Okay. And so how long would you like to cool?
Please adjust your mic.
Yeah, Dr. Jayakavya, Dr. Jalil, I think you might have to take over.
Yes, sir.
Yeah. So how long would you like to cool?
Rewarming, ideally point, we have to decrease by 0.5
How long?
degree.
How long would you like to cool?
72 hours.
Okay, we like to school for 7 hours.
Cooling has to be
Okay,
given for 72 hours.
Jacob, do you know may know
Hello,
the
sir?
reason why you want to cool for 72 hours? What is the reason for cooling for 72 hours? What is the pathophysiology behind it?
Sir, therapeutic head cooling decreases cerebral blood flow and metabolism, sir, and it will decrease the free radical mediated injury.
No, I'm asking why do you need to cool for 72 hours?
Why not 48 hours?
Basically,
Reperfusion injury takes time.
So what is primary neuronal injury? What is secondary neuronal injury? When does it happen? And how long does it take to manifest? And what causes
6 to
primary
24
injury?
hours, sir.
What is the pathophysiology of primary neuronal injury? Whenever there is hypoxic ischemia, what happens?
Primary.
Dr. Jacob, you're not audible. Hello?
We are not audible.
Hello, sir.
Jacob, you're not audible. Please come again.
Sir?
Not audible. Khalil?
So in case of hypoxia, there is depletion of anaerobic metabolism take place, and depletion of energy leads to damage to ATPase pump. So influx of sodium and calcium leads to activation of other enzymes that leads to primary neuronal death.
Primary neuronal death is not because of activation of enzymes. It's basically because of cell swelling and cell lysis and necrosis.
Cell lysis and necrosis.
Yeah. So secondary, when there is a pump failure, what happens? There is release of glutamate. And there is neurotoxicity. There is increased glutamate, which can act through NMDA receptors, which will increase your calcium influx. What happens when there is calcium influx?
So it brings the enzyme like protease, catalases.
Yes. So there's activation of all these lipase protease enzyme because of calcium influx, which will lead on to apoptosis.
Apoptosis.
And there are also the increased free radicals as well during this period. So where is the role of therapeutic epitomic here? It's more during your secondary neuronal injury. Okay, and this continues for 72 hours. So it reduces apoptosis, reduces inflammation, suppresses microglial activation. So thereby it protects them. It cannot be reducing your cerebral blood flow.
Okay.
Okay. Kiru, sir?
Yeah. Fine. So how would you follow up this slide? I think this must be the last slide, isn't it? Do you have any more slides, or this is the last slide?
Follow-up of the common high-risk groups, so they are advised to visit high-risk newborn clinic.
So what are things you look up in the high-risk newborn clinic?
So they are asked to visit at 2 weeks, 6, 10, 14 weeks. And at every visit, feeding and dietary counseling should be given.
Okay, so one is nutrition, because these children can have feeding problems. They might have a problem with weight gain. Okay, fine. Then
Growth monitoring should be done at every visit. Adequate pain gain is there or not.
Okay. Then
neurological examination, whether they are going in for any long-term sequelae or
like, what else you would like to look for?
Stiffness, sir. Stiffness in upper limbs and lower limbs. They can do
something which we discussed in the before.
Neurological.
So anthropometric, what are things you will monitor? Apart, you said weight. Anything else?
Head circumference.
Yes, head circumference is absolutely important. Then And then milestones you would like to
loss.
monitor for these children. Okay, fine.
Yes, sir.
Any specific scores you would use? Any of the scores you can use for monitoring the milestones?
Trivandrum developmental score or Denver developmental scale.
Okay, DDST or one of those you can use then.
Then hearing evaluation should be done. Then visual examination for ROP. Early stimulation by
term baby.
For vision.
Yes, you need to follow their vision, but not ROP screening.
Yes, sir.
Okay. Then apart from that, would you like to do a hearing assessment for these children?
Yes, sir.
So these children are at high risk for developing hearing deafness. So they need to have a hearing BERA for these children is an absolute is absolutely mandatory. Okay. Now there are some questions from our judge, Professor Srinivasan. How would you counsel the mother and the father? Dr. Jayakavya?
We'll explain the prognosis and we will keep.
Yeah, what will it tell? I am the father. I want to know what is going on.
Sir, we have to explain about the developmental. The child needs continuous monitoring.
See, you need to simplify. I'm a layman. So you need to keep it very simple. You need to keep it as simple as possible. I'm a layman because you're explaining to the father and the mother, isn't
it? Baby's development milestones has to be explained to the parents, or if it is not,
Hello?
Hello, sir. Sorry, sir.
So one is, you said is about the milestones. Okay, you want to tell them to follow the milestones. Okay, fine. That's one. Then anything else?
Next, hearing, sir.
Okay, then. What
Vision.
other aspects you would like to counsel? Can this child have a behavioral problem? Can this child have a seizure later on? Can this child have a, how will he do at school? So those are all aspects which you probably need to address and then tell the parents, okay, and there might be problem, but it is something which we cannot prognosticate as of now. And then it has to be only identified for follow-up. These children would need a yearly stimulation therapy and of course, other kinds of occupational physiotherapy. Okay. Now the other question, which was very relevant, actually I wanted to ask and I forgot, was this child was given anticonvulsants even on day 8. Would you like to continue anticonvulsant for this child or not? And how long would you give?
Sir, up to discharge, we have to do a neurological examination. If the examination is normal, means we can stop it abruptly, sir. Else, it has to be continued up to 1 month. At the end of 1 month, we have to again do an examination. If it is normal, we can taper and stop over 2 weeks, sir. Else, we have to do an EEG. Based on the EEG, if EEG is normal, means we can taper over 2 weeks. Else, we have to continue for 3 months. At the end of 3 months, we have to again do an examination. So every 3 months till 1 year, we have to do, and based on the examination findings, we have to taper and stop, sir.
I would like to have the opinion of the consultants. So if a child is having seizures.
So, I mean, personally, I don't continue to have anticonvulsant for these children because most of the studies which have come right now have clearly shown that there is no correlation between the acute event and the long-term continuation. So basically, we are giving a unnecessary medication for these children. So most of these children, I would stop unless the child had a continued seizures, even let us say beyond day 7 of life, or is significantly neurologically abnormal. And again, I personally won't bother doing an EEG for these children. I mean, I think clinically we take a decision clinically rather than EEG, even at 1 month or 3 months. If the child has got a development delay of significant action, then yes, consider continuing anticonvulsants. But otherwise, I don't think EEG is absolutely essential for these children. Dr. Balakrishnan, your opinion, please.
Yes, sir. Sir, here we again, as we consider it like an asymptomatic seizure. So once the insult is out, we don't need to we don't have to continue anticonvulsants forever. If the baby is neurologically normal, I think we can stop seizure medications by day 5 to day 7. We don't need to continue them forever. And the chance of recurrence of seizures is also not high in all these babies.
And then the next question, sorry, the next question again from Dr. Srinivasan is that what would you like to consider? Sorry, would you like to do a neuro image in this child again?
Yes, sir. EEG has to be done.
Why? We just now discussed and then said that this child, it's an acute event, the event is gone. Most likely this child will not have another seizure. So unless this child has a seizure, I don't think we need to do an EEG. That would be my personal practice. But regarding the neuro imaging, would you like to do a neuro imaging for this child?
Yes, sir. MRI.
When?
At 4 to 7 days of it.
Now you are seeing this child on day 8. You find this child is neurologically normal. So would you still consider doing an MRI?
Yes, sir. For prognosticating as well as for seeing any injuries there.
The head circumference is going normally. Still, you would like to do?
Head circumference now day 8. No, sir. We have to. Now
See,
we will not.
Follow up.
I think Dr. Balakrishnan said no poor man's MRI. A child on day
Dr.
7
Jacob,
feeding
what
very
sir
well.
is asking is on follow-up. If the head circumference is normal, if the head circumference is increasing normally, would you go ahead and do an MRI or?
Sir, in our center we.
Okay, fine. I think most people will probably not do it. I don't know what. Maybe it's being done as more as a investigative procedure, but the indication is not there in a child who's growing normally, who doesn't have developmentally normal child who has got a normal neurology. There is no strong indication to do a MRI for this child because the clinical features are far more reflective of what is going to go on rather than our investigations.
But
so
as long as the frontal is open, we can do ultrasound to see the ventricular size.
Yes, sir.
What do you think?
Yes, sir. Yes, sir. Actually, absolutely, sir. We don't need to.
PRC sir has also raised one question. PRC sir has raised the question.
Yes, couple of questions.
The mother wants to know if it can recur in next pregnancy. What do you think, and what do you think is the reason for birth asphyxia in this child? Dr. Jayakavya?
Sir.
So the mother wants to know if it can recur in the next pregnancy. How do you answer her? This will be a genuine concern of any mother.
Sir, but the pregnancy has to, as of now, there is no risk factors from mother side, sir. So pregnancy has to be planned and it has to be monitored. Intrapartum monitoring has to be enhanced, sir. So.
Yes, two things which you probably should say to her is make sure she gets delivered in a center where she has got intrapartum monitoring, number one. And number two is make sure that there is a pediatrician or somebody who can resuscitate the baby. Not necessarily pediatrician, anybody who knows resuscitation properly at the time of its delivery. But it can still happen because even though it might be an isolated event, she might be unfortunate and it can happen. So what do you think is the reason for asphyxia in this child? Probably our last question. I think that will wind up.
Sir, no antenatal risk factors and intrapartum risk factors. Might be if monitoring, like the intrapartum monitoring, we could have helped this baby, sir. And resuscitation in a higher center by a trained personnel.
The mother had sudden rupture of membranes and loss of amniotic fluid.
No, sir.
No, you said that this thing
she's not aware of that, sir.
Yeah, aware of that, and so that caused the problem.
See, very often this is a common scenario where there is no obvious explanation. Only thing is it's difficult to explain it to the parents. So it is something which we have to accept and then say it is something which is not, we are not aware, we cannot give you a cause. And I mean, I can't think of any other reason, because she was probably one of the well cared for antenatal mothers which we can come across with all her visits and all her care, antenatal scans and whatnot. Okay. Anything
there
else?
have been studies world over also to say, like over the last few decades, there have been very good improvement in neonatal care, but still the rates of cerebral palsy has not come down that fast. Like how our preterm survival rates are improved, but the same cannot be said for cerebral palsy rates. The cerebral palsy rates are still not come down as much. So there are uncharted territory which you do not know. There are a lot of factors which we are not aware, so which are still playing a role. And Dr. Jayakavya, is there anything recent advances with regard to, as you know, therapeutic hypothermia is not going to treat really entirely. So it's going to improve the outcome and reduce the death and improve the outcome to a certain extent. Where any other drugs which can be given in order to, in addition to therapeutic hypothermia, which can help these babies. Yes, absolutely. So erythropoietin is on the horizon. So probably it's in the safety, and probably we would see it if it works in the next couple of years. So this we call it therapeutic hypothermia plus. So therapeutic hypothermia plus, we need some more drugs in order to further improve the outcome in these babies. And erythropoietin has a role both. How does erythropoietin help?
Inflammatory mediators. It blocks the inflammatory mediators.
It inhibits apoptosis, inflammatory mediators. And the other interesting point about erythropoietin is it also helps in long-term neurogenesis and angiogenesis. So long-term neuronal healing also helps, not just acutely, but also for a chronic state.
Okay, I think we are coming to the end of the program. We have just got 4 more minutes. So anything else? So let's, unless Dr. Balakrishnan, you want to say anything?
Yeah, well discussed.
Yes, sir. Thank you.
Thank you, sir. Thank you, sir. I think the Jayakavya, she did a fantastic job. I don't think either one of us were very kind, and most of the answers she did very well. And
Dr. Jayakavya, on question, how will you counsel the mother now at present situation? Hello?
Make the mother feel guilty.
No, how will you counsel the mother at present situation? No, how will you counsel the mother?
The baby will improve, sir. Baby is doing good now, sir. At the time of admission, and now the neurologically improved baby is having good neurological outcomes, sir. So the baby's outcome will be normal, so no need to worry, sir. Frequent visit, I will advise the mother to come for frequent visits so that we can early pick up the anything is abnormal, we can early pick up, sir.
Can I just add saying that one point I'll never say is don't need to worry. Okay, you have to be, see, you cannot absolve them of any, because it's possible that that this child can have any other problem or even a sequelae of this problem. So you need to tell her that there are risks which are involved, but most likely this child may not have a high risk problem, but you need to have a follow-up. I mean, I'm sure all of us had instances where mothers have never turned up and later on found to have cerebral palsy or whatnot. What are the complications?
Another important thing is sensory stimulation as much as possible by the parents.
Dr. Jayakavya, don't tell that don't worry. That's very important. That means the mother may ask why that no worry, why you are asking to come regularly. Follow. Okay, that's why you have to, what Thirumugan said is correct. Okay, you have to really clearly tell, but you always give the positive things first. Okay. So don't discourage or negative things first. Okay. Right.
Yes, sir.
Yeah, Dr. Sir, PSC sir is that. PSC sir, comments.
You can stop sharing your slides, please.
Sir, it's one of the very wonderful discussions I listened to. So really, very good job done by the students, Dr. Jayakavya, Dr. Jalil, and Dr. Who's the other one? Nikita. Yeah, and they are very, very systematic. The presentation was very good, and the preparation was excellent. They have gone through all taken the pains, as Professor Srinivasan has said, of capturing the exact moment when it's like teaching slides, the teaching pictures they have taken for all the reflexes. So it's really their painstaking efforts. I congratulate them. So, I mean, it shows the commitment. Okay, so I really wish them all the good luck. Okay, so I also wish the mentors who prepared them for this task. It's not easy to face two neonatologists and young and brimming with a lot of knowledge and energy. Okay, so this is a tough task, and you really face the situation very well. And regarding Dr. Tirumurugan and Dr. Balakrishnan, so I really enjoyed their discussion. So there are a lot of learning for us. Thank you, sir. Thanks a lot for the professor, Teni Medical College also for the students. I just had one doubt. Where is this baby born? Where is this baby was treated? I thought it was in Teni. Then I saw some GKNMC. So was the child from Coimbatore or from Teni or from where?
GTMCH, sir. Government Teni Medical College and Hospital.
Oh, okay. I saw it as GKNMC. So I was wondering where this child, from where it went. Okay. Government Teni Medical College. Okay. Thank you. Thank you so much for the wonderful job you have done. Okay.
Srinivasan, sir.
Actually, wonderful discussion and very well presented, very well discussed. And of course, very important is the counseling, because nowadays counseling is part of the examination. Marks are given in some universities specifically. As you said, guilty feeling must not be made, and very cautious thing has to be done. And of course, follow-up is very important. And sensory stimulation of the child as much as possible, with parents taking time to be with the child as much as possible during the developmental phase. They did a wonderful job. I enjoyed thoroughly. And thanks to all of you for providing this platform to teach me pediatrics once again. Thank you.
Thank you, sir. Dr. Elilasi, Madam, Director ICH.
Sir, as usual, a wonderful experience. And seeing it's a beautiful presentation, beautiful pictures. It shows not only the standard of the student, the standard of the ward and the care, the nice bed sheets, the way, and the beautiful photography. It was a very refreshing session and a very reassuring session that they have children coming with HIE stage 2 and they are giving a good outcome. Hopefully, it was very nice, and really the mentors, the grilling neonatologists, everybody did a good job. Thank you for this opportunity.
Thank you, madam. Thank you.
Thank you, madam.
Thank you.
That's Selvakumar, sir.
I thank Dr. Balakrishnan sir and Tirumurugan sir for their excellent discussion, sir, with our students. I once again thank you IAP TN officer sir for giving this opportunity. And thank you all the panelists, sir, for a wonderful feedback. Thank you very much, sir. Thank you,
sir. First of all, I really congratulate postgraduate, that's Jaya Kavya. I think she has answered very well. And another thing is that slide making, that follow-up, the total follow-up of the baby is very excellent. Okay. I can
that make things very clear.
Yeah.
To prognosticate, yeah.
And another thing is I have seen a few PGs only, they're taking photography and they can see the close follow-up of all the milestones, even, and what are the stages, what's the condition of admission, and how they treated and recovery. I think it's excellently they're done. So really, I'm happy that postgraduates they have to develop this kind of habit. That your documentation is must. That's for future teaching also and for remembrance also. I'm really happy. And I think the young brigaders like Tirumurugan and Balakrishnan, that excellent discussion. They're done very well. That's actually really happy that both Tirumurugan and Balakrishnan handled very well of this neonatal case presentation. And on behalf of IAP TNSC, I thank today's Teni Medical College students that were excellent presentation, and Chairperson Dr. Selvakumar and Dr. Balakrishnan and Dr. Tirumurugan. And today is always encouraging us is Dr. PRC sir, always is the first person to come and will lot of questions will put. And Dr. Srinivasan, as usual, comments. I think it's a really excellent godfather like our postgraduate continuous medical education. And Dr. Elilasi madam, I think she's in spite of busy working and ICH director, she's always participating. and he's encouraging us, and he's giving valuable comments. And really,
sometimes I join late, sir, because when
yeah,
I come in
I know
sessions,
that I know, but even she's very that I'm so happy that they're so committed and helping us to run these programs. I think in spite of busy schedule, I think everybody is participating, and even if you take it at Srinivas or not, that 18 hours he's in front of laptop, I think. Okay, so really I'm happy that everybody is encouraging us to go on this program. And once again, I thank everyone. Thank you, sir. Thank you, sir. Thank you.